kind of gets us to where everyone should have seen the nice handout that went out to everyone, so I hope a lot of you, I had kind of encouraged everyone to send questions ahead of time, but I didn't really see too many filter through, so hopefully the content we covered today will answer a lot of those questions that you have, and we'll have a question-answer session at the end, so if you come across things during the presentation that you want to ask a question about, please just make a note, and then at the end we'll offer some time for you guys to have those answered. Okay, so kind of our initiatives today, we're going to learn those several things on the left. The required elements, we're going to go over some things about implementing, especially for those that really haven't started the ball rolling and want to keep moving forward. Kind of a quick review of the electronic systems versus the electronic health records. Briefly on care transitions, coding, billing, and those monthly activities. Really what I'm hoping for you to understand when we're done today is the importance of the care plan, you know, what is really required versus what's considered excessive. 24/7 coverage, I've given a few examples that come out of the manual, kind of those options, a brief overview kind of to understand really what's required there, because I think sometimes we're overthinking that process. Common barriers and strategies will be covered throughout. We'll go over the codes that are available for you as an RHC and FQHC, and briefly again to talk about how we can control that time that we spend with the patient to accumulate those 20 minutes, because any of you that have started those conversations know that it can start to accumulate to more of closer to 60 minutes, 40 minutes instead of that needed 20. Okay, so let's first go over the elements that CMS requires. These components are the ones necessary to enact your CCM program. You definitely have to use a CMS certified electronic health record. We'll go over these each individually, so I won't add insight as I read through these, but you have to build your comprehensive care plan, the 24/7 coverage. Your patient has to have access to successive routine appointments, process for transitions in care, and how you're sharing that patient information. You have to provide patient with enhanced communication possibilities, and then of course you have to accumulate those 20 minutes of time per month. Another item that could really go on there is the general supervision requirement, which changes the direct supervision. That only applies to the CCM program itself and doesn't change any other aspects, especially in the real health clinic setting. Okay, so let's talk about our electronic health record first. What we want to focus on here is the information I'm providing is really what CMS requires for these items. You can go above and beyond, but at the minimum, these are the things that they feel have to be located in there. I know that some of you have enacted your whole CCM program inside an electronic health record and aren't really using too many other tools outside of that, and that's fine. At this point, though, CMS feels that the demographics, the problem list, and the medication list, and the med allergies and non-med allergies, you have to include both. All of those need to be housed and recorded inside that electronic health record. The requirements have to meet the standards of December 31st, the previous calendar year. They haven't updated anything since the 2014 criteria, so at this point, your current certification standards will need to meet that 2014 CMS criteria. Anybody doing meaningful use should be up to date and should not have any concerns. But if you are not sure how to answer that requirement, you definitely need to talk with your IT people to see what level you're using and if any updates need to be done to make sure that you're meeting those requirements. The only other thing that they require is that a copy of the patient care plan needs to be housed within the electronic health record. That does not mean you have to create it in it. You don't have to build it in there, but a copy can be scanned in and kept within the electronic health record, and that will meet that satisfy that requirement for them. So those of you that I've had some misunderstand that think, you know, they have to use their EHR to actually build the care plan and utilize it within it, that's not true. You can use, there's a million options, and you can print off from another electronic source and then put that copy into the electronic health record. Okay, so let's move on to the care plan, because this is a big one. This, the comprehensive care plan, or the other word is patient-centered care plan, it needs to account for all these items within that care plan. You can't just, pull open a care planning tool and think that you can, enact those protocols that are in there and meet the needs of the patient. As far as CMS is concerned, it needs to be comprehensive, which includes basically head to toe and meets all needs. So it needs to assess for the physical, mental, cognitive, psychosocial, and environmental needs, not just that functional. It needs to contain problem lists that outline how you're going to manage symptoms, your interventions and measurable goals, what your outcomes have to be. You need to include, now I want to kind of clarify, because the care plan itself can house all of these items and then you'll meet those requirements, or you have to have a process in place where those items are accounted for and how you include that information during your care transition process and how you provide that information to your patient. Because ultimately these items are really goal towards helping the patient. So if you're not sharing this information with them, you're really not utilizing the tool per the CMS regulations. So they talk about an inventory of community resources and support that are available. We do have, I did complete my manual and my tools. Unfortunately, the editor is still not finished with all of those. I had hoped to provide links to everyone today so that you could upload those. But it looks like it may be prolonged about one more week, and then I really want to push those out to you guys so that you're able to look through them and use them. But I do have bits and pieces of them embedded in this presentation today so you can kind of see what I'm talking about. So those resources, you really need to go through and have a list of resources, and I will show you a snippet of that here in a few slides, so that you can understand and point out to the patient where they will go if they need help or assistance with something in their home life, such as power assistance, Meals on Wheels assistance. It doesn't mean that you expect them to set them up, but they need to know that these are available, especially if they aren't communicating all their needs with you and they get their family involved. At least you have a tool available to them so they can reach out for help if they are not comfortable letting you know that. Hopefully, as you build your rapport with your patients, they should be transparent with you and let you know everything that they need. But unfortunately, you know that you deal with some patients where they like to be as independent as possible and will try to reach out to those places on their own. Make sure you include medications and how you're going to manage those. You need to have a process in place for those care transitions. Those include, and we'll talk more about those, but those include going to the ER, the hospital, being admitted to a nursing home, being admitted to assisted living, or having a stay there and then returning home. Anytime the patient leaves one healthcare setting, which we include kind of the home setting as a healthcare setting because they're managing their health in that setting, to a different healthcare setting, those transitions need to include the information that will be able to be provided so that they know how to take care of that patient adequately. You also need to keep in mind that you need to coordinate that with the outside agencies and specialists as well. So referrals, and if you're using home care, any kind of visiting nurses type of situation, even CNAs, you need to make sure that you're communicating that important patient information so that they can care for them properly. This care plan also needs to, and I think people forget this, it needs to outline who's responsible for each element of an intervention or a treatment. Is it the patient who's doing it? Is it you that's doing it? Is there another individual involved? Is there a family member? So when you're writing out those goals and interventions, it needs to identify who's going to complete those. And you also need to include a schedule that shows when you're going to periodically review and revise that care plan. Now, as you move forward with your patient and things change, you're probably going to constantly update it. But if for some reason you have a patient that doesn't change much, it is kind of, CMS hasn't put an actual time frame on it, but they did recommend that at least yearly it should be reviewed and updated. And everybody at that time should sit down and of the care team members, and you should look at all the elements. You should be including the patient in that conversation and make sure that everything is up to date and that nothing needs to be changed. The other thing to think about with this care plan is it must be created electronically. CMS demanded that in their requirements. It's outlined in there. So what that means is you have a million possibilities in how you're going to create a care plan. Even if you utilize a paper tool, and we'll talk about that, that you utilize to have the patient fill out and gather information on, it still will need to be transcribed over into an electronic system. If you have the ability to send out secure messaging to the patient and they're a little bit savvy on technology and can use a computer appropriately, you could be able to send that care plan gathering information paper to them and they could fill that out over the system. The reason I talk about this is the tool that we built for the care planning is actually an electronic tool and can be manipulated right inside the system that you open it in. If you're able to embed that in your system that goes out to the patient, you're going to be able to bypass the whole step by allowing the patient to type answers in there. That will have to be an individual process that you'll decide on with your care team, and just make sure that everyone's educated on how you're going to do that moving forward. Okay, 24 access to care. This has obviously created a lot of different conversations and some barriers and struggles for everyone, but it really just kind of comes down into two parts. The patient has to have access to the physician or a qualified healthcare professional or clinical staff members during normal business hours. Most clinics are open. That's not the barrier here. You know, having the patient call during the day to meet those basic energy needs should be not a problem. Those can be addressed. The problem comes to the non-business hours, after hours. They still need to have that same access to a physician or qualified healthcare professional or a clinical staff member that will be able to address their care needs. Of course, basic needs, but it's the urgent needs that changes that scenario a little bit. As long as the healthcare professional on the other end of the phone that is talking with that patient can prescribe whatever is needed to meet those urgent needs, then you're fulfilling that process. If they are not able to answer those questions or they're not familiar with the patient, they need to be able to reach out to somebody in the practice setting, a healthcare professional that will need to be, they can reach out to a care team member that is familiar with the patient to answer a question if that's all that's needed. But if it escalates to the point where the urgent need needs medical attention, a nurse that is a care team member cannot prescribe a treatment, they will need to be able to reach a provider from the patient's care practice setting. So that process needs to incorporate that a provider for the group will need to be accessible for these patients, and they will need to be aware of those patients' needs so that the urgent need can be taken care of. A lot of times if you're partnering with an emergency room, the medical staff on call there typically can take care of the urgent needs, but if they have questions, they will need to be able to reach out and talk with you. The grumbling part kind of comes when everyone's talking about how do we share the patient information. They may be able to make it through the treatment process without looking at that care plan or the CCD or the other information that you're going to provide them, and that is fine as long as the optimal treatment outcome is happening for that patient. But if they need to have access to that information, it needs to be made available. Many options have been, I'm hearing a lot of places fill out a binder, and that binder is housed within the ER or wherever those calls are taking place. If you utilize a system that is an electronic system that everybody has access to, that's obviously the easiest solution, and then anybody can just access the system and look up the patient information. Not every system has that ability, though. So that's kind of where the barrier is. The other conversations that would need to happen is if people from the care team are actually rotating some kind of call schedule, or you have nurses on a floor, if they can have remote access into that system to access that information as well, it kind of takes away that need to have a bunch of paper copies floating around, and they would be able to remote in and look up the information that they need. it's probably the most recommended option, and you would need to involve your IT team to talk about the ability for identified people to be able to log into the system and look up that information. I've worked at several different facilities where we could remote in from home, so I know that the capabilities are there. You just need to talk with the IT team to get that set up, because it's not something that you and your supervisor can do alone. They will need to grant access and set up those portals for you. It's important to understand, again, a CMS requirement is they want that patient to have successive routine appointments. A lot of people don't quite understand what exactly does that mean. It just means that the patient needs to be scheduled routinely with the same provider, same care team member, and if you can schedule those appointments ahead of time, you're going to meet those needs. What they want to avoid is that chronic care patient has a lot of illnesses and they call because they need to come in and see the doctor, and then, no appointments are available. With someone that's in a chronic care management program, we know that we're going to see them how often, and when they're there for that appointment, you should technically schedule out their appointments for the next several months, if not the year. You would want to explain that to the patient ahead of time, that in this program we like to have a very coordinated schedule, because I know sometimes patients like to say, well, I'm not quite sure what I'm doing there and then, but if you explain to them the expectations ahead of time that we will be scheduling out your appointments with your same provider every visit for the next year, or at least for the next 6 months, then they will be more compliant if they know that that's an expectation. This should include actually sick appointments and acute appointments as well, if possible. I know there are going to be times either a provider is not available, or somebody's sick, or their schedule's too full and you can't switch anybody around. Those are okay. If it just needs to be the optimal treatment for the patient. So if they need to see another provider to meet those needs, that's okay. You don't have to get them in with their normal provider. But the assigned care team members should probably be overseeing that to make sure that whoever does take care of them has the proper information in front of them to understand those little unique treatment options that that patient requires versus a typical patient. What I say with that for is every CHF patient can be different. What works for one patient may not work for the next, and for the purposes of continuity of care, we really want to make sure the provider that's taking care of them understands what will and won't work, so that we avoid those unnecessary tests and duplication of medications and so on and so forth. The patient should always interact with that same care team member, because you're going to overall reduce errors in treatment. You're going to allow that rapport to build between you and that patient, and the same with the provider. The patient learns to trust you because they become familiar with you as you fulfill their needs and wants. That trust builds more, then they start to become more open with you, so then overall communication will improve. You want your patient to want to communicate with you so that you can be effective in the program. And the more you communicate, the less needy your patient can become, because they start to feel comfortable with the care that you're going to provide them, and they no longer worry that, is this pill actually going to be refilled? Are they actually going to remember to put me on that schedule? Is this test really going to be ordered? Once you've built that trust, they know that, yeah, my care team member, Mary, is always going to follow through and take care of that for me. So the phone calls start to decrease, and they start to kind of let you coordinate their care the way you're supposed to. Also, you become more knowledgeable, obviously. The more you deal with the patient over and over again, you will remember, and I know a lot of you. I've talked with people in different clinics where you can talk about a single patient and they can pretty much prescribe to you the treatment that you've done for the last 2 years for them. So that the more you consistently see the same patient over and over, the more knowledgeable you become. Okay, so care transitions, this can be confusing for some people, and I get a lot of questions on this. What exactly are the parameters? What does it mean? As you can see in the little diagram, it's really just about that patient information and that continuity of care document. Per CMS, they require that a continuity of care document is included in the process. That middle circle touches out to all those other places, which means that information needs to cross over in between all of those places so that every place the patient is receiving health care from, they should all have the exact same information in front of them. Again, it builds trust, it builds communication and collaboration amongst all the different providers and agencies involved. It reduces errors. It also reduces cost so that you don't order unnecessary tests and treatments. It's safer for the patient. You know, that will include the ER, hospital, admits and discharges, any referrals out to other providers or specialists. If a patient switches to a new provider and you're no longer going to be following them, it's still your responsibility to forward those plans of care and all that pertinent information so that next provider can do what is best for that patient. Healthcare settings, an admit or return to home. That includes, again, those nursing home, assisted livings, any private sectors that a patient may be, your patient may be admitted to and receiving care and then going back to. So that continuity of care document is really just a simple form. If you're utilizing an electronic health record, typically you can just print that CCD right out of there. It needs to kind of contain the demographics, of course, medications, all those allergies, any treatment plans that are in place. It definitely needs to include that pertinent care that is unique to that patient. It's also suggested that a copy of that patient care plan accompanies that CCD so that all that information is in front of that caregiver. CMS was not real descriptive when they basically put that it must be shared in a timely manner. They did not put a time frame on that. They just feel that whatever is timely is considered within a time frame that allows for optimal care for that patient. So if you're taking 5 days to share a CCD and the patient's in and out already, I think that's probably not going to be considered timely. I would think within a day, 24 hours, you should have the ability to share that information in some way, shape, or form. There always are going to be certain instances where maybe the care transition fell under the radar and you weren't aware, or it's on a non-business day when the clinic's typically open. You'll need to kind of discuss how you can account for those days so that that information does make its way out. You can share that information through an electronic source. If you, again, share an electronic health record with a system, obviously they can pull that out, or you can send it through there to them, grant access, remote access. You can secure email or fax, or any other solution of choice that allows that information to make its way protected over to that next healthcare setting. CMS also wants that patient to have enhanced communication possibilities. This means that your patient needs to have more than the ability to just call you on the telephone. They want that patient to have some kind of interaction that involves either an electronic system or, you know, such as asynchronous, non-face-to-face methods such as a patient portal. Again, secure messaging. You're going to have some patients that want to text because they can and they understand it. You'll have some that will want emails, some that are really good at patient portals, some that want emails to come through. So you'll need to talk with those patients ahead of time to decide what is their technology understanding, what ability do they have to understand those and utilize them, and then kind of go from there. You will come across occasionally a patient who has absolutely no technology understanding and will not utilize it. As long as it's available, and if the patient chooses not to use it, that's okay, you've met that requirement. Okay, so your 20 minutes of non-face-to-face activities. I did not list here what those include, but when you are able to get the manual from me, there are sections on all of these items that we're reviewing today in detail, so it will kind of outline what can or cannot be considered an activity. The main things to remember are the items that I've outlined here. It is per calendar month. That does not mean 30 days. It means from the 1st to the 30th or 31st of that particular month. So January 1st through the 31st is considered a calendar month. February 15th through March 14th is not considered a calendar month. So it's very important that everyone utilizing a CCM program and tracking tool for those 20 minutes needs to make sure that you're tracking that correctly and not just utilizing a 30-day window. You can count the provider or clinical staff time only. There's been a big discussion about this recently. The activities that involve the patient only, those are not activities that can count in your 20-minute total. So if your patient's filling out a form at home, you cannot count that. You can count the time it took to prep the form. You can count the time it takes to interpret the data that they return on the form, or the time that it takes for you to do any research, referrals, education with the patient, education tools that you're preparing for that patient. If you have a patient portal and you're prepping the portal with information that's going out to them, or again, you're looking at data that's coming back, or you're building that care plan, all of that clinical staff time can be counted in those 20 minutes. Your first initial month, it's going to be very simple to accumulate those 20 minutes because you're going to be doing a lot of activity to get them set up in the system. But again, be prepared that you can't count that patient time. If you're counting time for the CCM, it cannot be included anywhere else. And that needs to be very clearly outlined. So for instance, I have some clinics that I've heard will bring in patients for a patient visit, and then we'll also go into the room and discuss CCM with them at that time with their chronic illness and set up things. If you're going to have a visit, the patient comes in, you need to be able to carve out the, say, 20 minutes for that visit that happened for the patient visit. Now, chronic care management time will need to be an additional 20 minutes separate from that, and you would need to be able to prove that time on a tracking tool. If you count the visit time of 20 minutes and then you also put that over into the CCM time, that's double dipping, and you can't accumulate those minutes into both items. You have to separate them out. So it would need to be a total of 40 minutes for that day to be counted in both programs. It is definitely suggested, I would almost say it's mandatory that you have some kind of tracking tool that's going to allow you to track those activities, what's being done, how much time was spent on it, what you did, what was accomplished. You can either develop your own in electronic source, or we have our Rounding Well program that they've did a few changes to take away the patient tracking time because that was being tracked before and counted. That will be turned off, and you will only be able to track your time. Anybody that's utilizing Rounding Well will understand what I'm talking about. Those of you that still need education will be traveling around and trying to help clinics get some patients into the system and understand the ins and outs and how to kind of utilize that tool. You would open up a risk for the patient, you would do that activity, and then you would log how much time it took you to do that, and then the system itself will track an accumulation. You definitely want a tracking tool because if the end of the month is coming and you don't have enough minutes in, you're going to want to monitor that through the month to make sure that you meet those 20 minutes. CMS is very adamant about that you cannot round up. So if you had 19 minutes and that's what's documented, you will not be able to bill out for CCM, and you will have basically done the 19 minutes, which is great for the patient, but you won't be able to recoup that through your billing process. So it's very important that somebody is monitoring that either daily or weekly so that you know that you're meeting those needs of the patient. Again, I have a tracking tool that can be utilized electronically and manipulated in whatever Word program you open, or and you could embed it somewhere else. And then you can constantly update that in the system and save it so that it will tally for you. And then you can keep track. And then there's a nice column that says the patient has met their goal for the 20 minutes for the month, and that billing can ensue. Okay, so let's start talking about, the acronym we've been using is We Want to Build Our Boats, which is our CCM program. Anybody that saw our previous presentations knows that I basically correlated that your CCM program is a giant boat that houses everybody in it, and the success of that CCM program or your boat will depend on how strong you build it. So there's some key things to consider. Again, we have our fun rowing team that you saw before. It's a big, everyone is a giant team. Everybody has a purpose. They all work together. When you're building that boat in your CCM program, I've had a lot of conversations with different individuals who are rushing through that program to kind of get it set up. Everyone's pushing, we want to bill, we want to get it started. But please, you need to slow down and not rush through those items, because anytime you've ever built something that you did too quickly, the outcome is structurally poor. If you want to have a strong boat for your CCM program, you need to make sure you're going through all those components and you're building them correctly. I've had other programs tell me that they were pushed to kind of start getting patients enrolled even though their program was not complete. You cannot begin offering CCM to patients before your boat or your program is completely built. Just like I asked there, you know, just as you would not go out and half a boat into the middle of the ocean to sail because the outcome is going to be a detrimental one, you will not want to enact your CCM program until you have every element in place and accounted for. The flip side to think about that is not only will it fail, but if you suddenly were audited by CMS to see the structure of your program and how you went forth, they'll clearly be able to outline that different aspects of your CCM program were not built yet. For example, if you enacted, maybe you don't have your 24/7 coverage completely mapped out, but you've enrolled 5 patients this week and you're going to begin them in the program, and then this week they have urgent needs and one of them calls after hours, and then there is no set process in place, the outcome for that patient could be detrimental, and then obviously there's liability issues for that for you and the provider and the practice. So again, make sure all elements are in place and accounted for before moving forward. You have to remember that this process, it can be overwhelming when you're learning all this information, but it's really, it can be simple, and we need to keep it simple, and you need to avoid what is unnecessary. I see so many people, they get passionate about it, they want to get going, they want to do this, and they want to do this for the patient, and I'm going to start this process over here. When you add too much at the beginning like that, it's too overwhelming, and technically you start kind of losing your progress and you start to get discouraged, and it's harder to move forward. You can add more of those items back later. Once you become proficient at it, you've got enough patients in, you're doing a great job, you can start adding those little extra twists here and there that just kind of pump up your CCM program more, and it can have more interactions with your patient and offer more structure. But at the beginning, you need to kind of stick to that simple plan and make sure you just have those requirements in place and then learn to grow from there. Please remember that the frustrations and all those barriers that everyone shares with me, they are similar for everyone. Nobody is unique here. Everybody is facing those same struggles. Everybody's in it together. So don't feel like there's no solutions, because even people that have enacted their CCM programs, they had those same struggles at the beginning as well. But once they found the solutions, they did move forward. Remember to keep everyone involved. I see some places they hire a care coordinator and then everyone just kind of filters away, and that poor care coordinator is sitting there trying to figure it all out. You need to have those ancillary people involved. You need to have that support system in place until you get to a point as that person who's constructing that program where you feel you can do everything by yourself and you don't really need as much of those people sitting alongside of you. Then you can start doing some of that on your own. Otherwise, that teamwork needs to be in place, because that's what keeps our boats floating. So make sure, you know, if you need administration to be involved to make those important decisions, you need to have those conversations so that they understand that you still want them there and that you need them there. Okay, so we reviewed our required elements. Basically, you need to remain positive to all of this. It can become very discouraging in your process when you're trying to implement it. You're overwhelmed, you're frustrated, you keep hitting barriers, you're not quite getting answers for things, but it's very just simple. All of those elements that we just reviewed, if you can have an answer for each of those, you're going to have a strong boat. All those elements in place equals a strong CCM program. You definitely need to utilize checklists. Those tools that have been developed will be shared, I promise, and I keep talking about these, but they will be shared with you shortly. Checklists will keep you organized. when you have a checklist and you're able to check some of those things off, you feel like you're actually making some progress. When you don't have a checklist and you're just trying to remember different aspects of this and that, you're not quite sure where you're at and you don't really see any gains. So I definitely suggest that some kind of checklist is pulled out that maps out the elements that are involved and what you need to do. Again, we have a checklist tool that does that for you. It's probably one of the first things that I'll be able to share with you guys is the tools, because those are being finished up. I believe by tomorrow I might be able to email those out to everyone, so I'll be looking for those. Instead of just trying to tackle everything at once, you need to identify what's easy. You do that with any project. Well, this is easy and I know how to do that. General supervision, obviously check. You know, everybody understands what that means. That's an easy one. You know, filling out a CCD. Oh, well, we have an electronic health record. We can print that right off. So that's another thing that you could check off your list. Go through and get all of those easy things checked off, because it starts to shorten that list of things to do. And then you'll feel like you're actually, well, this isn't so bad, because half the list is gone now and I'm down to just these simple things. When you've identified objects that are harder, you need to simplify those down into smaller tasks. That will help you get through that process, and just instead of just trying to think of it as one large task, break it down into little tasks so that you can just chip away at it. If you're stuck, move on to a different task, because that just frustrates you further and you'll probably kind of stall there. So you need to kind of pass it over and go to a different one. Now remember, everybody's CCM program does not need to look the same. Everybody does different things. They will all look different, and that's okay, because everybody's going to be unique. What is important is how strong your program is. So again, building those elements and making sure they're proper and in place will make you have a strong vote. Okay, please avoid quick fixes. I've had a lot of these conversations as well, where people are pushing, we want to get the CCM going, administration saying, well, just do this, just do that. These typically are only temporary solutions. A lot of times when those solutions are identified, they're really not considering what's going to happen in the future with that. How does that change as we move forward? Typically, they create more problems with those quick fixes than they've solved one problem, but probably created a couple more. It can affect the overall integrity of your whole CCM program. And if you have a team member that's being assigned a solution that they feel is a quick fix, but not really the solution that they wanted, that team member will become dissatisfied and could eventually leave. I talked about that with the 24/7, you know, a lot of people talking about the different call solutions. If that is not something, if the process that's being decided on is not something that fits for you long term, then you need to have those conversations at the beginning. I think sometimes we get stuck and people above us look at us and say you need to do X, Y, and Z, but if it's not really something that fits, you need to advocate for yourself so that another solution can be found so that you stay happy and you stay in the program, and that another solution with the team work all involved can find something that works better for everybody. You need to ask those questions. Does the process have a typical workload? If the solution that's being provided is above and beyond typical workload for a normal day for a person, that should be a red flag that if you were to put that typical thing in a job description and it's scaring applicants away, then it's probably not a typical workload. Is the person that's responsible for that quick fix that's being assigned to them, are they supportive of it, or do they seem disinterested and not real on board? Again, another red flag. Even if they're not sharing that with you, you would need to identify that there must be a problem and try to open that communication. Will this process still work 3 years from now? That's an important one, because what works today, how do you sustain that 3 years from now? Will it still work then? And as I said before, was another problem created because of it? Okay, so the next steps. All your process for elements have been identified, and your checklist is complete, so we know that we're going to be able to do the elements. We're moving forward. Your next steps are to get your care team assembled. Some people may have already done this, and that's okay, but you also need to make sure that everybody's roles are identified If there is a title that needs to be accompanied with that role, you need to definitely outline those and make sure everyone's aware of what the titles are and what those responsibilities are for that title. You need to assign those responsibilities. Anybody that's done a team activity knows that if you don't assign out the responsibilities, it typically falls onto one person to get everything done. So those expectations and outlines need to be done ahead of time. That will avoid dumping work onto one individual versus another, so it evens out the workload. Identify what forms you're going to be using. We've talked about a lot of different forms. You need to definitely have an outline that says we'll be using this form, that form. It seems like a lot of checklists and stuff, but it will organize you to have those forms listed out so that everybody understands what will be used for what. You need to add the education for those forms to an education list, which is our next section. You need to outline your education needs. That will include all your care team members, any forms or processes or where to find things moving forward. We talked about this before. You need to include your front office staff. Their role in this whole process is very important. Typically, they're answering the phone. Those CCM patients are calling, and if the front office staff has no idea what a CCM program is or which patient is a CCM patient and who's not, they're not going to be very efficient at helping you with your process. They need to understand and be able to identify who the CCM patients are, how they're supposed to be and expected to schedule those appointments. So they need to know those CCM patients who their assigned provider is, who their assigned care team member is, and help with those scripting for those phone calls. Your billing staff needs to be educated. They need to know the process that's happening, what forms are in place, and how you will communicate when those patients are done, what those expectations are. Make sure they're aware of the codes that are available. We'll get to those shortly. Also, your providers, they need to make sure they understand, again, the CCM program, what their role in that is, what they need to talk with the patients about, what they're expected to chart. Because, again, if everybody is not educated to the same point in time, your CCM program is not going to move forward, and you're not going to be as effective, and you're probably not going to be successful because if any of those points in care fall out, the patient won't be getting what they need. Once this has all been kind of formulated, this is really when you begin making your patient list for your CCM program. Now you can start kind of identifying. You may want to target a certain diagnosis or a couple diagnoses, whatever is prevalent in your area. One practice may have a high prevalence of CHF and diabetes patients, or another may have COPD and hypertension. So you need to kind of discuss that with the team or your provider, whoever, and identify those targets. Use a risk stratification process. I talked to one clinic who they were told just sign up everybody who has Medicare. That is not appropriate, as not every Medicare patient is appropriate for CCM. And to be as efficient as possible, a care coordinator needs to have a designated population of patients. CCM is for a definitely identified group who will benefit from those services. A typical Medicare patient that maybe has a couple chronic diseases but is self-sufficient at home, is pretty interactive, takes the pills, doesn't see the doctor other than the typical routines, and doesn't visit the ER or hospital, and only takes a handful of meds, that's really not the top of the list of who needs to benefit from that CCM program. So make sure that you're using a risk stratification tool that takes into account those items, multiple medications, multiple chronic diseases. The higher the number, the higher they rank. Frequent ER visits, frequent hospitalizations. Again, there's a tool for this that will be shared with you so you can kind of see those categories and how to score that further. If you utilize your own risk stratification, that's fine. Let's talk briefly about the care plan. Okay, so I see a lot of people go above and beyond with the care plan, and I see some that kind of underwhelm. But here is a comparison. This patient basically shared with you that they just don't drink enough water during the day, and they've had some dehydration problems in the past. On the left, we have a typical nursing deficient fluid volume care plan, and if you typically read through that, you'll recognize that as nurses. And I'm not going to read that verbatim, but it really goes into that high-level nursing lingo, and these care plans and goals and interventions are to be shared with the patients. They're to take a copy home so that they can follow it and understand what's expected of them. They're not going to understand the majority of what's written here, nor does it make sense to them, and they're probably just going to ignore this because they're not really sure what they're supposed to be doing. Over on the right is as simple as it needs to be. It's patient-centered, so we need to remember that. It's about them and what they need to change in their home life, and how can we word that so they understand. The fluff on the left is great, it's thorough, but it's really more than it needs to be. Typically, a system that has care plans built into it will generate those kinds of items. We need to keep it to the right. Basically, the patient's going to keep a pitcher of cold water in their fridge. Maybe part of the problem they shared was that they like cold water and they never have it available, and maybe they can't fill the ice cube tray. Maybe they just constantly need reminders, so they're going to set a timer, and to keep track of it, they're going to keep a simple sheet on the fridge. Basically, their goal is, I will drink 8 glasses of water each day. This isn't a typical, this is just an example. You know, with other things, obviously, you would tweak that to be whatever glasses of water need to be incorporated, or if that patient needs education on, you know, teas and coffees and the different things not to drink. But again, if we keep it simple, you can see there's a huge difference here. We're kind of overkilling with the left side, and it's not really helping the patient because they're not going to understand. These snippets on the right that you're seeing, those are actually pulled out of the template for the patient-centered care plan that we have. I wanted to share these so you can just see a copy of this goes home with the patient, and it kind of mirrors exactly what we were just talking about. It's very simple. The goals are about the patient. It's not about what we feel our nursing education has taught us to implement, you know, with our nursing books. It's about what does the patient need and what needs to change for them, and how can we word that so that they will work with us to do that. You need to use tools that start to pull information from the patient when you're building that care plan so that you can identify risk factors. As you can see, the section on this care plan that the patient would be filling out says things I want to improve or change. It asks them, okay, so what would you like to change? What would you like to do differently for yourself? So that they actually will write in there, you know, maybe it's about the water. I want to drink more water every day. So if you're using a tool that pulls that information, it's simply better than just asking, you know, so what do you want to do? What do you want to do in your home? What should we do? This tool, and I'm going to share some more sections, will slowly pull information from them so that those things that they can identify when you ask, you can identify in those different sections. As you see, My Personal Goals and Interventions, this is actually a section you would fill out with them based on the information we're about to look at. So the questions on the form, and it doesn't have to be a care plan form, this could be a questionnaire that you're giving to the patient or sending to them at home before they come in for a visit. They're very non-confrontational. We're just simply asking, and we kind of motivate them with the headings that are on there. I want the people working with me to know. And as you see, we can go through a lot of things. How are they living? What challenges are they faced with? What's their main language? I learn best by. Sometimes we forget to ask those things. Maybe they don't like looking at pictures and videos, and we're always putting, you know, some kind of video in front of them when they're in the office. Maybe they do best just by speaking. Access to care and the different aspects that impact their health care, dietary needs. As you can see, also I have concerns about the following. Again, this helps you identify my ability to manage my chronic conditions. If they're putting yes there, you definitely know that they're struggling at home to take care of themselves. My ability to manage my medications. Okay, so now I know that they're probably not taking their medications correctly. They don't, different things will identify they're having trouble making food for themselves. They're having trouble getting dressed every day. And if they do mark, I would like to discuss further, that definitely identifies that you need to enact a goal and intervention for that. A couple more sections that are included on there. We talked about the community resources and assistance that's available. This is a nice section that's included on there because you can go through and in your area, you know, once you do this for one patient, you probably typically won't have to repeat it again, because you'll know the answers once you've researched it once, but you can put in that information that answers all those sections and the phone number. You can track if the patient refused that help, which is great because this is a nice tracking tool and it's also an educational tool so that you can kind of keep track of what's working. You have comment sections. You can alter these or update them because they are electronically manipulative so that you can go in the system and update them. Those questions, again, ask about kind of compliance answers. And then you can also put that whether it was addressed or if a referral or assistance was done. For example, I frequently forget to take my medications. Maybe you involved a family member with that to fix the problem. That was part of a goal and intervention. Or maybe you referred them on to home care so they could do Medicare management and come in and do assistance with bathing. But that's the kind of thing that you can track. Also, it's nice summary tool if you build something like this even in your own electronic health record or however electronic source that you're using. If you can include sections like this in those, these are great resources to go to kind of get a summary of everything that's needed by the patient, what assistance is in place, and et cetera from there. Okay, so the lovely section that we'll go on to, which you guys have been waiting for, I think, is coding and billing, because I get a lot of questions on the different codes. So I've narrowed it down to basically if you're a regional, a rural health clinic or a FQHC, these are typically the codes that are available for you. These two tables, and I hope everyone can read these okay, we'll be uploading this webinar, so you'll be able to print it off. And this is a nice summary table that lists what the code is, whether it's kind of the description. There's a section there that talks about whether the RHC, FQHC can utilize that code. It kind of gives a brief summary of rates. The final column there identifies the codes that cannot be billed along with that initial code. I do provide all of them because if we do have anyone that is not a regional or rural health clinic, then you need to be able to utilize those other codes and you need to understand what those are. These are also outlined in the manual in more depth. The next few slides are going to provide a little bit more information, but I just wanted to make sure you could kind of see this summary tool because it's a nice go-to that if you're able to print that off and have that posted somewhere, it's a quick reference to understand the ins and outs of what that code means. Okay, first code, obviously, that's available for you guys is a 99490. That's just the basic CCM service, the 20 minutes. You can bill that only once per calendar month. All patient copays and deductibles apply. The next one, you do have the ability to bill for the advanced care planning. This is a confusing name because it's not really about the care plan. It's about the advanced directives and those items that go along with it. It's provider time only. It is not clinical staff time. It's 30 minutes of face-to-face time with that patient or their family representative or their health surrogate or whatever. You're going to discuss those advanced directives, fill out forms. They don't have to be filled out. They can be filled out at another time. There's no active management of chronic conditions during this time. This 30 minutes, if you do bring the patient in for a normal visit and then you tack on the advanced care planning, you need to be able to separate the time and account for both. So 30 minutes is just for the advanced care planning. You would need to be able to carve out your 15 to 20 minutes for that visit as well on top of it. Co-pays and deductibles do apply. For the RHC, FQHC, you can bill those, and again, I'm not going to go through all the wording, but those visits that they can be billed along with, that's fine. You can submit those, but you will only get the all-inclusive rate, or the FQHC will get the PPS rate, not that national payment amount that you see posted. So again, if your normal reimbursement rate is $80 per visit, that's what you'll get for that visit if you bring them in to just do advanced care planning. You can bring that patient in, schedule them for advanced care planning with the doctor, and you can bill for that as a patient visit, and you'll get that all-inclusive rate. But if you do couple that with another code, you will only get paid for the one visit. So you don't get paid for both. It would just be the all-inclusive rate. Keep in mind that if you do the annual wellness visit along with the advanced care planning, you can put in that modifier 33 and it will waive still that patient copay, which typically is waived during the annual wellness visit. The advanced care planning add-on is available as well, which is an additional 30 minutes. I don't know how helpful this code is for you guys, but if you're typically wanting to show CMS how much time it takes to take care of your patients and it's not really affecting your reimbursement either way, I would typically want to be putting that code on so that they can get a clear picture of that the time for these patients is a lot. You guys have access to the transitional care management codes. Again, you reach out to that patient within 2 business days. One of them with the higher complexity, you have to see them face-to-face with the provider within 7 days. The more moderate complexity is within 14 days. It's required that you do the med reconciliation either with that within that 2 business day. Some places are actually sending a nurse to the home to that patient. They can do med recs at that time, but the doctor would need to follow up with that. The TCM period starts that day of discharge to the next 29 days, so it's a 30-day period. You have to keep in mind that day cannot overlap with CCM, the CCM time. So if you happen to have a month where your TCM runs and starts on, let's just say January 15th, patients discharge, their TCM starts obviously mid-February, the TCM period is going to close, and then those last 2 weeks of February, you're able to get your 20 minutes of CCM in. That is a typical situation where you could bill for both, and that will be fine. But if they overlap at all, you would have to pick and choose which one you're doing. In the manual, it talks about that more in depth because there are some nuances there, and you can do a little calculation. You do not get the TCM rate. You basically, that is the national payment amount. You get your all-inclusive or your PPS rates again. For those, the copays and deductibles apply. There's no restriction on how many times you bill that as long as you meet your service requirements. If, what I forgot to mention is the patient does expire before that 30th day, you cannot bill for that TCM program. 20 minutes per month. I wanted to talk to you guys real quick about this because we're kind of running short on time, but it's hard to stick to that 20 minutes as some of you are finding out. So it's really important that you work with that patient ahead of time and do scripting with that patient. If you let them know that, okay, Mary, I'm going to be calling every month and we have a set amount of time that I'll be talking with you, or if you're calling twice a month, you would let them know and carve out that time that, we have 15 minutes. The phone call will last 15 minutes, and at that time, I don't want you to feel I'm being rude, but I will probably remind you when the 15 minutes is almost up, as I always want to make sure I'm meeting your needs, but sometimes, I have other patients that I will be talking with after you, so that if you remind them that with every phone call, you can kind of restrict that excessiveness when they want to talk about their gardening, or, that their cousin's coming to visit or Aunt Martha passed away. If those things are necessary because of depressive moods or things, then obviously you want to address those. If the patient is still sharing information with you and is definitely in need of some kind of intervention, you would not want to cut that phone call short, obviously. But helping with the scripting will definitely detour some of that excessiveness. Collect what information you can and utilize whatever interactive tools you can outside of the phone calls, so that will decrease the amount of time that you are actually on the phone unnecessarily. I don't want to say unnecessary because, the patients benefit from the time you spend with them, but then it takes away from time that you can spend with other patients, so you have to be mindful of that. We talked about motivational interviewing in our last Care Navigator meeting, so I just want to remind you of that and utilizing those tools on those phone calls. That is outlined some in the manual, so that there is a section on that. Real quick, the 24/7 call coverage. Again, the interpretation of this can be very confusing. To understand content, it really needs to be broken down into 2 separate statements. You need to provide 24/7 access during normal business hours, and then you need to provide that 24 access to staff during non-business hours. During normal business hours, you should be able to meet all basic and urgent needs. The after non-business hours is really focused on, yeah, basic needs, we can meet those if they're detrimental. If it's something that can wait, the patient will be referred to call the care team member the following day. If there are urgent needs, there needs to be a process in place, and we talked about this, so I won't go into great detail. There needs to be a process in place where those urgent needs can be addressed. That patient's assigned provider needs to be accessible, and it clearly states that in the CMS guidelines, that somebody from the patient's practice setting has to be accessible to discuss those urgent needs. If that's another provider that is aware of the patient's conditions, that's fine. If it's just consulting with the care team member to provide a little insight, that's fine as well. But once it comes to scripting to need treatment or medications, a provider will actually need to be contacted. A couple examples. Group of providers, and these are on-call examples on kind of how to cover it. A group of providers within a shared practice rotate the on-call and after-hours call services in place that receive the calls. The on-call service redirects the patient to the provider or contacts the provider with the patient information. The provider then speaks with the CCM patient and provides the required assistance. Keep in mind that all providers rotating call will need to either be knowledgeable about that patient or have the ability to access that personal information so they can make those decisions. Example 2, utilizing a local ER. The staff there helps cover that after-hours care. The ER staff can probably, and the qualified professionals can offer the help and basic needs for that patient. But if the patient has more urgent needs, again, the staff needs to be able to follow standard protocol. And if that standard protocol cannot meet those needs, they need to be able to contact that provider again. The staff will, the ER staff will take guidance from the practice provider to meet the needs of the patient then. The qualified healthcare professional talking with the patient needs to act within his or her scope of practice and job description. So if somebody clerical is answering the phone in the ER, they are not the correct person to be interacting with the patient. All Incident 2 rules apply. You can look those up per CMS or in the CPT manual so that those incident rules apply to that ER setting. They need to have the ability to contact, again, the provider, and they need to have access to the CCM patient information if that need arises. So you need to have a process in place on how you'll meet that need, as we discussed before. Okay, we're at the point where if anybody has any questions, we will need to and sorry here, give me just a minute. Okay, does anybody have any questions at this time?
Lisa, this is Reagan Brown Memorial.
Hi, Reagan.
Hi, hey, can you send out those slides again? For whatever reason, I'm not seeing that I got those.
The one that we just went over, or a previous one?
No, this one and the checklist. Have you already sent those out? This one that we just went over?
Nope, the editor still has the manual and a couple of them. I'm actually finishing up some things with her today, and then once I have all those finalized, I'll be sending out like a mass link to everyone so everybody can start downloading those and utilizing those tools. The manual is just a little bit, I'm hoping to have that next week, and I'll make sure that all of you guys get those.
Okay, thank you very much.
Welcome. Any other questions?
Can you hear me, Lisa?
Yeah.
I'm sorry, excuse my voice. This is Kim Estel from Gibson Hospital. I just had a question. We've started billing for patients, and we've only done one so far, but I know the first phone call was really extensive just because you're asking so many questions and then all the time to get that care plan set up. So would you still just charge for the 20 minutes, or do you do that complex code? I mean, because it seems like everybody would have to have that code for that first call because it's going to probably be over 20 minutes. I'm just confused.
Right. The complex care code I think that's the 99487 and 89, if I'm correct. Those aren't available for the RHCs and FQHCs. You can utilize the code, but there won't be any extra reimbursement for those. So if you're a non-RHC, obviously you would want to utilize those codes because there's significant reimbursement attached to those. You would just want to make sure you have your documentation in place to support that those actual minutes were met above and beyond the normal 20 minutes. So I guess the question...
that are non-RHCs, most of them are RHCs. But if they are a non-RHC, it's okay to use that complex code for that, especially that first phone call.
Yeah, they should be eligible to submit that claim or that code on their claim. If you're ever unclear, and I've always suggested this to everyone, that if you need to verify with your MAC provider or your fiscal intermediary, you would always want to check with them to make sure that those codes are available to your typical setting, and they should know whether it is or not. Sometimes it's easier just to do that than to go through all the claim denial process.
Oh, okay. So, I'm sorry, one more, probably a stupid question, but if they are a RHC, should you go ahead and put in that time, or should you just stop it at the 20 minutes?
I would, if you can.
I know Trudy had said that probably could just, like, if you spent, 2 hours doing their care plan or something, that you should put that in still.
Yeah, I would always accumulate how much time it takes because, again, you want CMS. So kind of going back, you want CMS to clearly see the big picture of how much time you're spending working for those patients because ultimately it can affect your reimbursement rate at the end of the year. Based on the amount of time it takes to take care of those patients. So you want to definitely coop those codes. If you're able to put them on and it doesn't hold up your billing process, then you would want to include those so they correctly see how much time you're spending with that patient.
Okay, thank you very much.
You're welcome. Are there any other questions? Okay, at this time, everyone, if you don't have any further questions, or if you think of one, 30 minutes from now, you can definitely email me at here at ICANN. It's L Schlatman, which is SCHLATMAN at ICANN.org. Please forward those questions to me. I'll be happy to answer those. We'll be uploading this webinar onto the site so that you guys have access to it, and I will make sure everyone's aware of when all the tools and the care plan and the manual are available. I will be sending those out to everyone so that everyone gets a copy. So please, thanks for joining today. I hope this answers some questions for you, and if there's further education needed, please forward those requests to me and we'll schedule some things in the future. Thank you, everyone.